Good evening. I'm Deb Gerard, the Executive Director of IMPACT Melanoma, and I'm so happy to have you all with us tonight. We have an exciting program to share with you tonight. But first, I'd like to tell you a little bit about IMPACT Melanoma. We have lots of new people with us tonight, and I'd like to share a little bit about what we are, what we do, and who we are. Um, First, I think it's important to get to the beginning. And what got us to this place of talking about skin cancer and melanoma? So here are some quick facts. Having more than 5 sunburns doubles your chance of having a malignant melanoma. That's a really important thing. And part of the reason that a great deal of our programming is about taking care of kids and families so that kids are not getting sunburns that will come back to hurt them as they get older. So how do we do that? We use SPF 30 or a higher sunscreen because it reduces the chances by 50%. So sunscreen is for us an important tool to fight against these issues. Um, Melanoma is the deadliest form of skin cancer. So we hear about lots of skin cancers. We know that we spend millions and millions of dollars every year taking care of skin cancer. Uh, and the interesting part about this is that skin cancers and melanoma are really the skin cancers that are the most preventable. So that's why we're here. Approximately one person dies of melanoma in this country about every hour. And one of the things that we're very cognizant of is that melanoma is the second highest cancer among 19 to 29-year-olds. Many of you will understand that one of the issues that we have dealt with a lot in the 25 years that we've been around is tanning, both indoor tanning and outdoor tanning. And while we've worked very hard to get legislation to stop kids under the age of 18 from being able to use tanning beds. One of the things that we're beginning to see again in 2025 are young people using tanning beds. So that's why tanning has really caused melanoma to be very high in 15 to 29-year-olds. So what are the most at-risk groups? White men over 50, families with a history of melanoma, and more people of color. So those are the facts. And so what does IMPACT Melanoma do with those facts? We created a vision. So our vision is to save lives and reduce the incidence of melanoma in this country through prevention and education programs that increase awareness, promote early detection, and prevent skin cancer. The second part of our mission is to provide support to melanoma patients and their families. So that outlines the work that we do at the foundation. How do we do it? We create a partnership with organizations around the country that are aligned with our goals. And these are the programs that we provide out in the community. Practice Safe Skin is our anchor program. This offers sunscreen dispensers to communities for any target audience around the country. And for us, sunscreen dispensers are a tool. They're a tool in the fight against skin cancer, just as sun protective clothing, wearing hats, and sunglasses, and seeking shade. Those are all the pieces of the puzzle that we bring out to communities and provide some training. And who do we provide training to? Well, one big group is outdoor workers. They have 60% higher risk of developing cancer. We provide programs that offer education, sunscreen, protective clothing, and portable shade. Uh, a few years ago, we started a very sweet program called No Sun for Babies. And this is addressing new parents as they just start their journey at taking care of their babes and talking about what we have to do to take care of kids under the age of 2. Um, Skinny on Skin is a program that's been around for over 10 years. And we developed this program because we realized that beauty professionals, estheticians, tattoo artists, these are people that all see your skin more than your doctor does. So we provide training to those folks so that they can look at the places like your scalp and your back, and their job is not to diagnose. Their job is to let you know what they see. It's been a very successful program, and many, many people come back and thank their provider for getting them to a dermatologist to have something checked. Impact Shade is a newer program that we've working with communities across the country to provide temporary shade particularly in urban areas, and to provide UPF protective clothing to people as a way of protecting themselves in the sun. Be Skin Smart is one of our newer programs, and this is the program that provides education to middle school, high school, and college age people across the country. And this is a program that teaches people uh, how to promote a healthy, sun-safe life. So big project. We are very fortunate that we have medical students across the country that work with us to provide programs. So this is what we do at Impact Melanoma. And in addition, we provide support groups for melanoma patients and their families. And we provide a program called Billy's Buddies that's meant to provide mentors and some financial assistance for patients as they try to navigate their treatment. So that's who we are. I encourage you to go to our website, look at other events and programs that we provide, and there are always volunteer opportunities. And thank you for being here tonight. I'm going to introduce Kelly Brega. Kelly is our manager for support services. So if you're working in any of our groups, you'll get to know Kelly very quickly. Go for it, Kel.
Thanks. Thanks, Deb. Good evening, everyone. As Deb mentioned, my name is Kelly Braga, and I'm the Support Services Manager for IMPACT Melanoma. We offer multiple support groups available nationwide for patients and caregivers, as well as our peer mentoring program that Deb mentioned, Billy's Buddies. So more information about those support services can be found on our website. So we hope that you are, if you're interested, that you check them out. Now, I'm honored to present our speakers for this evening. Our first speaker is Dr. Jesselyn Ubelacker, an assistant professor in the Department of Molecular Metabolism at the Harvard T.H. Chan School of Public Health. Dr. Ubelacker earned her PhD from Harvard Medical School and her MD from Stanford University. Her research explores how the tumor microenvironment influences cancer metastasis. During her postdoctoral work, she discovered that melanoma cells in lymph nodes experience less oxidative stress and form more metastases than melanoma cells found in the blood. Today, her lab focuses on uncovering metabolic and lipid-based vulnerabilities in cancer cells to identify new ways to prevent cancer spread. Next, we'll hear from Dr. Kyle Holen. As a medical oncologist, Kyle saw firsthand the devastating effects that serious disease can have on patients and their families. This is why, after completing medical school, residency, and fellowship, he dedicated his life's work to finding better therapies for those who desperately need them. He started by conducting research, education, and patient care as an associate professor at the University of Wisconsin. He continued his mission by leading multiple clinical research teams. Dr. Holen is currently the Senior Vice President and Head of Development, Therapeutics, and Oncology at Moderna. We would like to welcome you both this evening. And with that, I will turn it over to Dr. Ublacker.
Thank you so much. It's so wonderful to be here with you this evening, and I'm really looking forward to presenting a virtual open house of our lab. I will start off by explaining a little bit about what we do, and we will follow the progress of what a patient sample analysis looks like in a bench research lab. We're zooming in from the Harvard Chan School located in the Boston medical area, which is right here. And I love starting off with this slide with this location because it really helps to show how integrated academic medicine and basic biological science research is to being able to collaborate with hospitals and to have this workflow between patient samples and what we call bench science, which is what our laboratory does. It's known as bench science, as you'll see in a moment, because we have physical benches where we're working on pipetting cells and testing drugs that would then potentially go onwards to be developed in pharmaceutical companies and industry, similar to what Kyle will be speaking about next. So the exciting thing about being in the Harvard medical area is there's over 7 hospitals within this location. You can see here on the map, Brigham and Women's Hospital is nearby, Boston's Children's is as well, Dana-Farber, Beth Israel are right off this edge of the map, which really facilitates close collaboration with clinicians who are treating patients with melanoma, and our lab, which is trying to work on very early stages of new biological discoveries that might lead to new therapeutics that can then be translated back into this clinical context. So to share a little bit about the academic lab structure, this is our laboratory team. So I lead a team of 9 or 10 individuals, depending upon the year, trying to train all of these individuals who are on different trajectories in learning and science. So academic science is made up of PhD students. We have a couple PhD students in our lab who are training and earning their PhDs in science, and then will go on either to pursue research in industry or pharmaceutical locations or in academics, or even to go outside and into science policy, science writing. And in our laboratory, we also have some postdoctoral researchers, and postdoctoral researchers are researchers who do a second project after their PhD, where they've learned all the skills of critical thinking and how to make scientific discoveries. And then they do a second project in a different lab to gain more skill sets and to have more independence in guiding their own project to set themselves up for future developments of building their own lab or moving into different careers in science. We also have research assistants who help facilitate all of the projects in the lab. And we often have clinical fellows who are practicing clinicians or residents who are working in our laboratory as well to help bridge this gap with the clinic and with the basic bench research that we do. So our lab specifically studies the roots of metastasis. And here you can see melanoma represented in this orange blob from this video from NIMUS 3D, designed by the Morrison Lab, which is where I did my postdoctoral work. Melanoma can metastasize through the bloodstream, but it can also metastasize through a lesser discussed route, which is the lymphatics, shown as this top band. And previous work in mouse modeling of melanoma has shown that melanoma cells, when they metastasize into the bloodstream, undergo this oxidative stress pressure, and it can cause the cell membrane of melanoma cells to cause the cell to die and rupture. And this is a process known as ferroptosis. So our lab really studies the ferroptosis process, this way of cells dying, to try to push these melanoma cells toward death. The interesting thing about the lymph node, which you can see here represented as in this bean-shaped structure, is that the lymphatic environment we found protects these melanoma cells from ferroptosis. And so it's a very cozy, hospitable environment for melanoma cells to live. And melanoma cells can undergo adaptations that then allow them to subsequently survive through bloodstream metastasis and then reach distant sites such as the lung. So a lot of the work in our group is centered on trying to understand how we can target melanoma cells specifically within this lymph node environment. Are there ways that we can push the lymph node to being less hospitable to prevent cancer metastasis disseminating past the lymph node, and how can we target the lymph node specifically in order to make more of these oxidative stress pathways that we know happen in the bloodstream. And so most of our laboratory's work is focused on several different projects trying to investigate early stage research about understanding this lymph node environment, which really has not yet been well characterized with some of the new technologies that we have available to us now because of recent developments in being able to analyze biological samples and biological tools. So our lab centers on using a technology known as metabolomics. And metabolomics is a very comprehensive technique that allows us to look at hundreds and hundreds of all of these small molecules that are taking place and changing within cells, within cancer cells. So we try to study how the lymph node contributes to these different small molecule signatures and to use that as a tool to identify new ways to block cancer progression from lymph node. So we're so excited because this leads to discoveries that are happening at the early stage research level, which I'm so pleased to share that today, actually, this came out from our lab. So it's a special day, November 5th, to share that this is an example of one such target that our group has identified that is hopefully able to help move the field forward in looking at this as a potential target. Now, the pipeline for a patient sample, when we're looking at analyses in our lab, these are all done through very comprehensive clinical studies that go through institutional review board approval. And so when many of you may have actually participated in clinical studies and samples and provided samples. So what happens when you provide a plasma sample, for instance, into the and then it goes to lab for analysis? These are things that I'm going to show you some videos of. For blood samples, we can use technologies like a centrifuge, which allows us to separate out different layers of the blood. And then we can sample this on our fancy mass spectrometry machines, which allow us to get this metabolic profile that I was mentioning. So I want to show you a little bit about the steps following a sample through our lab to give you a visual representation of what this looks like in a bench science lab. As I mentioned, it's called bench science. We literally have benches where our PhD students, our postdocs, and our research assistants work that are filled with all of this equipment and reagents, pipettes, tools, and technologies that are needed to study these early stages of research. And so this is what a typical lab looks like, and this is our lab at the Harvard Chan School. We also have designated areas to study particular aspects of science. So here you can see is an area where we can analyze proteins. Over here is where we can look at RNA levels, which are very specific markers that we're looking at in our melanoma samples. And we also have various chemicals in the lab that we use, which is the chemical station here where we can test different compounds and use a chemical hood for those as well. We have a large walk-in refrigerator, which is where we store all of our medias that we use to keep the melanoma cells alive that we're studying, because it mimics more of that human blood environment. And this is an example of a cold room in a research lab. So next, I'd like to introduce you to one of our PhD students, Alanis, who will talk a little bit about her involvement in sampling.
Hi, everyone. My name is Alanis Carmona. I'm a fourth-year PhD student here in the IMPACT Lab, and I am the medical liaison. Today I'm going to show you guys what we typically do when we get a patient sample. Aside from being a lab focused on melanoma, we also do some cancer work here. And so typically we have, there's a lot of collaborations that exist with clinical hospitals, and we have a current clinical collaboration with Beth Israel. And so what they do is they deliver to us a patient sample, which is here in my blue, as you can see here. And we have a blood sample. And typically what I would do is I would then take that blood sample, I would spin it down in our centrifuge. And after spinning it down, you would then be able to see the different layers, where you see kind of the plasma and just everything else at the bottom. And so for us, what's super important is that plasma. That plasma is what we take and we end up using specifically for us for omic studies.
So here you can see Alanis spraying down the biosafety cabinet, which is what we use to protect ourselves and to also keep our experiments very sterile and to control these conditions. These hoods have a specialized airflow that helps to protect the researchers when they're investigating different aspects of cancer, which is what she's preparing.
And because we do work in a biological safety cabinet and I'm working with a human specimen, we are always to wear gloves just because you never want to get any droplets or any exposure to the biological sample. And so now you're going to just see me taking the sample from the tube. So just transferring it and then spinning it down. And again, because this is all biological sample, we make sure everything goes in its own separate biohazard bag.
And so here's an example of a centrifuge, which spins at a very high speed to allow the different layers to settle out. And from there, we are able to take these samples and run them and analyze them on our mass spectrometry machines, which you're seeing here. So these are very fancy machines that pull the sample through and are capable of detecting hundreds and hundreds of small molecules that are present within the sample that we can then analyze to be able to look at different profiles under different conditions in patient samples, in our cells that we're treating with different early stage drugs. So this is an example of a mass spectrometry facility. Next, you'll hear from Midori, who does drug testing on melanoma cell lines in our group.
Hi, my name is Midori Flores. I'm a fourth year PhD student in the lab, and I've always been interested in exposure science, and now I'm studying the outcome, which essentially in some cases can be a cancer. So I'm really interested in the molecular mechanisms behind cancer for personal connections, but also just because of how much I am passionate about the research. And when we have a sample from a patient's cancer, we're able to test different drug compounds here in the lab.
And so what this testing looks like for testing melanoma cell lines that we use is that we can place these cells in this special media formulated to match human blood nutrients, and we can study these in this well format, which Midori is plating here. And next, we can keep these cells in incubators that mimic conditions of the human body. So they're kept at very special temperatures and oxygen conditions. You can see plates of cells here in this incubator. We finally can show you the different flasks where we keep melanoma cells, and this allows us to do different testings with different drug agents and to see how our treatments affect the melanoma cell survival. So this is one of the incubators that you can see is kept close to 37 degrees Celsius, which is close to human body temperature, and these are all of our different medias that we use for our cells. So I just wanted to give you a snapshot of the types of data that we can get from these types of analyses. So here you can see just an example of all the different listings of small molecules that we can identify. This is an example of a profile from melanoma cells from a primary tumor or a tumor that would be on the skin subcutaneously versus one from a lymph node. So you can see visibly there's a big difference between this blue block and this red block. So we know there's a lot of different profile changes to be able to investigate and to study. So our lab is primarily using this as a tool to identify new pathways and new small molecule changes that could lead to developments in being able to detect our ability to target this early stage melanoma progression to the lymph nodes. So I just wanted to provide a very high-level overview and a tour of our lab to show you a bit what happens behind the scenes when patient samples are involved. And with that, I would like to open up for 5 minutes of questions. If you have any questions about what it's like to be in a bench research lab, about the melanoma research that goes on, there's a Q&A box that you can please feel free to enter your questions in right now, and I will be able to answer those. And if you'd also like to ask questions online, you can also raise your hand, and I think there's an ability to ask questions there. So with that, I will open the Q&A while we're waiting for questions to come in. One aspect that I wanted to speak a little bit more about was how academic science fits into this greater goal that all of us are working toward, which is to develop new therapies and to accelerate the current therapies we have to make them better for preventing and stopping melanoma. One aspect of how academic science fits into this piece is that we're able to study very early stage mechanisms, but also to have the flexibility to study aspects that might be higher risk and more exploratory, because we are really trying to understand a lot of the biology and to publish that biology and that finding so that companies, industry can use those findings to hopefully build on what we're seeing in our system. The question that's coming in is, how long did this research take to develop? That's an amazing question. So for each project that we're working on in our lab, the academic labs each individual leads their own project, because in academic science, the goal is also to train individuals to become good researchers and good scientists. And so one of the beauties of running a research lab is we have 9 or 10 different projects going on at once. And some of the projects take 1 to 3 years to complete and are shorter term projects. Some of them will take more, 4 or 5 years to complete. The particular story that I shared with you today took about 3 or 4 years to complete, that we're excited to share with the entire field today. But most of academic research is dependent upon what direction the research takes, because our end goal for academic science is new discovery that can help contribute to the field. And so because we don't have clear clinical objectives that we're trying to meet or clear endpoints, it's really up to the researcher to decide when that study is finished. So I would say on average in academic science, it's 3 to 5 years, mostly because it's in a training environment. And so each individual needs to see a project through to also train them to be good scientists in the future when they're going forward and expanding the field outward in terms of the research and development. Great. Well, it's been so wonderful sharing with you today, and I will now pass it over to Kyle. Thank you so much.
Wow. Thank you, Dr. Ubalacher. You all are doing such amazing work. And it's this type of work that enables us at Moderna to do all the things that we're doing, including even the development of the COVID vaccine. It was based on the incredible work that people have been doing for many, many decades on mRNA science and lipid nanoparticle science, and that created the COVID vaccine, which we all hopefully benefited from, as well as some of the products that I'm going to talk to you about today. I'm going to quickly share my slides. Let me make sure that you can see them appropriately. And okay. So, as mentioned, my name is Kyle Holen, and I lead the development for oncology. And in particular, we have a couple of programs that are moving forward in patients with melanoma. We have a lot of programs at Moderna, and many of these are programs that we hope to help those affected by melanoma. IMPACT Melanoma is doing incredible work on educating and hopefully preventing anyone from melanoma. Unfortunately, we still have over 100,000 people who are diagnosed with invasive melanoma in the United States every year. So it continues to be a big problem. And so for those people where we can't prevent melanoma, Moderna and Dr. Ubelacher, we're here to help find treatments for those who are diagnosed with this disease. Last year, you all invited me to come and talk to you about our personalized um, vaccine treatment called 4157. You can see at the top of the list that is currently being studied in phase 3 clinical trials for melanoma. And we hope to have a readout on that phase 3 clinical trial next year. And I talked to you a little bit about the incredible science that has been done in order to enable this individualized therapy. Every therapy that's created is unique for each individual, and it's based on their uh, mutations in their individual melanoma that they've been diagnosed with. But this year and today, what I'd like to talk to you about is a brand new therapy that we're developing and studying called mRNA 4359. It is also being studied in melanoma and showing some really exciting results. So I'd like to talk to you a little bit more about that. But that's not the only melanoma treatment that we're studying. We also are studying another treatment called 4203, which is very, very early in development. We do have a patient who is enrolled in the study, and we're excited to see how that patient does. And maybe next year, I can talk to you about 4203. Across all of these therapies, however, what our plan is to have a treatment available for people across all different stages of their cancer. That includes for our personalized therapy in Tismaran, those who had a diagnosis, had it removed surgically, and are receiving what's called adjuvant treatment, which is a therapy that tries to prevent this cancer from coming back after it's surgically removed. But we also have therapies that we hope to help people who are diagnosed with metastatic disease in the frontline setting, as well as people who even have refractory disease. The treatment is not helpful for them, and they need further therapy. Let's then start talking about 4359. So this is a therapy that is directed toward of and the cancer PD-L1 that are present not only cells, and this vaccine teaches our immune system to fight the cancer and help create a more robust immune response against that cancer. We have studied this therapy in patients in a phase 1 trial. This is the design of that trial. We had multiple different cohorts and dose levels that we did to try and understand the safety and the efficacy of this trial. And we recently reported our results at a large oncology conference called the European Society of Medical Oncology Congress. This presentation was just a few weeks ago, October 17th. And what I'd like to share with you on this presentation is some of the information that we shared, where we enrolled 24 patients into the study. All of these had melanoma. They all had metastatic disease, and they all had multiple prior therapies, including immune therapies. And unfortunately, their cancer had progressed, grown, and spread despite receiving these therapies. When these patients received this therapy, they had side effects that were similar to what you might receive from a vaccine, which included some pain in the arm, some tiredness, and a fever. This was all quite manageable, and certainly much better than what you would expect from most cancer therapies. And what we saw in this cohort in terms of a response to the therapy is quite a few patients who had their cancer shrink. And in fact, one patient whose cancer shrank so much that we could no longer find it on scans. And that was a complete response that occurred in that patient. We were very excited about this response, not only the complete response, but many patients who had partial responses. And this led to further evaluation where we looked at patients who expressed those markers I mentioned that are targeted by the therapy. And in those patients who had expression of that marker, those patients had 2/3 a likelihood of having their cancer shrink and stop spreading from the therapy. And these treatments had very long-lasting shrinkage of their cancer and stability. And on the chart at the bottom right, you can see the number of days since treatment initiation. And those red lines represent the shrinkage of the tumor and how long those tumors were shrinking. And there are patients who had their tumors shrink more than 400, almost 600 days, where their tumors were under control with the therapy. So we're very excited about this therapy. We also looked at why do we think this treatment is working. And by looking at patients' T-cell responses and some specific types of T-cells, we better understood what type of T-cells activation was occurring and what they were activated towards. And this helped confirm how we were helping to boost the immune system to help fight the cancer. We plan on continuing to study this therapy by adding more patients into the clinical trial. We also plan on advancing into a phase 3 trial, similar to what we are currently doing with our personalized therapy. And then lastly, we believe that this therapy could also have benefit across other types of cancers. And so we're studying some patients currently with non-small cell lung cancer, but we'd also like to study other cancers, including esophageal cancer, gastric cancer, endometrial cancer, possibly bladder cancer, and head and neck cancer. So there are many other cancers where we think this treatment could be helpful. I wanted to spend the last few moments, a couple minutes left, just giving you an update on where we are with our personalized treatment that I discussed last year. We have completed all our enrollment in that study. We are waiting to see whether or not people have their cancers recur or not. Once we have a certain number of patients who have had their cancer come back, difference between the patients who received the individualized therapy versus those that did not. And then we will release the results and hope that this provides a benefit to melanoma patients. I will share with you as well that this is also a therapy that we have studied across many other types of cancers besides melanoma. We are currently running studies in lung cancer, bladder cancer, pancreatic cancer, and gastric cancer. We also have kidney cancer ongoing study. And so we're hopeful that perhaps this therapy can help a wide variety of different patients with different cancers. Okay, that was just a brief update of all the different therapies that we're studying in melanoma. And thank you for your time. Thank you for inviting me back. It's a pleasure to be here. Hopefully, the next time I give you an update, it'll be good news that our phase 3 study was successful. And similarly to Dr. Ubelacher, if anyone has any questions, I'm happy to answer them. And I think you can do so by either clicking on the Q&A box or raising your hand. Thank you. And I see a question already here about 4359 with T-cell mediated action work while taking immunosuppressive adjuvant therapy. So that is a great question. We actually are a little bit concerned about people taking immunosuppressive treatment, such as steroids or even anti-inflammatory medicines at high doses, because we're trying to have a more robust
What happened? Oh, there he is.
Oh, I'm sorry. I lost you. My
Yes.
apologies.
We lost you for a moment, Kyle. Welcome back.
My apologies. I think I was answering the question about immunosuppressive
Yes.
treatment, but we are concerned about immunosuppressive treatments on study because it could prevent the immune stimulation that we're trying to achieve with our therapies. So we ask people to try to avoid treatments like steroids when we're giving our investigational therapy to patients. And then I saw one other question about where the trial's being done. It's a great question. I had a picture of the world, and we have over 20 countries where our studies are active and we're enrolling patients. In terms of where our studies are being done in the United States, we have over 100 different sites around the US. And there are a couple of places, even here in Boston. Mass General Hospital is one site that has our melanoma study open, as well as our lung cancer study open. And there are many other sites throughout Boston and large metropolitan areas across the US. And then regarding side effects, has there been study into whether they are caused by immunotherapy or mRNA vaccine? Yeah, this is another really, really good question, and I didn't spend a whole lot of time talking about this, but we have looked at the typical side effects that you might expect from immune therapy, such as a drug called pembrolizumab. And then we studied the effects of pembrolizumab when we added the vaccine on top. And it turns out that we did not show any additive side effects from the immune therapy. The side effects from the vaccines that we're administering, either the 4359 or intismeran, seem to be fairly consistent with other vaccines, which are the pain in the arm, some fevers, and some fatigue. We've now treated over 1,000 patients, and we haven't discovered that there have been any other concerning side effects in patients with melanoma from this therapy. Well, there's a lot of questions. This is great. Thank you for all your questions. One other question here is about which age groups would benefit from the vaccine the most, younger individuals or older? What a great question. And my answer to that is I don't know. Um, we're studying age groups all the way from down to 18 years old up to people in their 80s. And to date, we haven't noticed any difference in how they respond to the therapy. But we will take more looks at this to see whether or not there's a difference. I will say that generally the younger individuals have more robust immune responses than older individuals, and so it's possible that younger individuals will have a better outcome. But to date, when we've looked at this, it doesn't appear that there's any difference. Another question about if successfully completing FDA approval phases, do you think mRNA treatments could become the first-line treatment for melanoma? Ah, great question. Possibly, I think they could become first-line treatment for melanoma. But melanoma is very difficult to treat. And so I see these vaccines more as partners in a combination approach where you can give multiple therapies all at once to have the best chances of fighting this cancer, because it's a very difficult cancer to treat and even more difficult to cure. And then maybe I'll just continue with the questions because there's so many great questions. Another one is, would this treatment be used as second line for patients based on individual criteria or for those who can't tolerate traditional options? Yes, for sure. We're studying this 4359, honestly, in second line right now. We're also planning on studying in front line. So we hope that these treatments can help all patients with all different scenarios of need for their cancer. And then another question about Keytruda immune therapy for melanoma. So I will say that Keytruda, which is also known as pembrolizumab, has been very effective for many people with melanoma. And if you have questions about whether or not pembrolizumab is a therapy that would be helpful for you, I would strongly encourage you to talk to your doctor about it to see if it's right for you. That is a very, very difficult question to answer without a lot of information about your underlying health, medical conditions, the other medicines you're taking, the type of cancer that you have. So I would strongly encourage you to have a conversation with your doctor about what types of treatments might be best for you. I was a medical oncologist treating patients for a long time and had to make those same decisions. And I'll tell you, I had a lot of time to go through lots of information about each patient to make sure that we made the right decisions. Okay, I think that was all of the questions.
Does anybody have any follow-up questions that they would like to ask of either one of the presenters? Looks like you have gotten them all. So thank you very much. This was a wonderful experience for our patients and caregivers. And of course, we would love to have you back to follow up on where you are in another year or so. IMPACT Melanoma does these symposiums twice a year, so we will have another one coming up in the spring of 2026. And I'm excited to share that at that point, we will be talking about a movie that IMPACT has been instrumental in called Conquering Skin Cancer, done by an Australian filmmaker and it really tracks all of the issues around what it's going to take for us to conquer skin cancer and melanoma. IMPACT is represented as a nonprofit, as the nonprofit doing prevention and treatment. And we're going to have a preview at an event that we're doing on November 21st, but the movie will be released in the spring of May of 2026 for Melanoma Awareness Month. And our goal is to get it everywhere across the country, and we'll be talking about that more. But we would love to have you here, and there'll be more information about that as we get closer to working this out. So if you have other thoughts about symposium topics that would be helpful for you, please share them with us. And we're very grateful to have you here and hope that you will be able to join us again. And many thanks both to Jess and to Kyle for their informative, helpful talks. One of the things we always find with our with people that join these symposiums is that they have incredibly fabulous questions and are very well versed in understanding their treatment and the treatment that's going on around them. So thank you for being here and being open to supporting our patients as well. So thank you all very much for being here. Please visit our website at impactmelanoma.org and let us know if there's anything else that we can do to support you or the communities that you live in. So good night and thank you so much.
Thank you. Good night.